Hi everyone. So in this video we're going to talk about the digestive system. We're going to go ahead and label these diagrams. It is a lot of information, but we'll get through it together. Just keep in mind that while I am only labeling the anatomy, you are still responsible for any comments on physiology that I may make, meaning that I can use any of this information on your tests and quizzes. So I highly recommend that you are not skipping through, but rather that as you're labeling your diagram, you are also taking notes. Okay? So let's go ahead and get started. We're going to be looking at this overview diagram. What I like about this diagram is on the left-hand side, you have the alimentary portion of the digestive system. On the right-hand portion, we have the accessory organs. What it means by alimentary, so let's go ahead and get that labeled. A is looking at the alimentary canal. And the alimentary canal is going to be any organ within the digestive system that food can pass through, and pass through directly. For any organs that are involved in the process of digestion, but food does not pass through, it's referred to as an accessory organ. Okay, so let's go ahead and focus on the left-hand side of this page. So everything that's a part of the alimentary canal. Right, so the first part of digestion is going to occur in the mouth. Okay, keep in mind your saliva is going to start to break down food. The process of digestion starts with an enzyme in your saliva called amylase. It's going to begin to break down carbohydrates and digest those. Excuse me. And then once you go to swallow, we call that section of your throat the esophagus. I don't think this is any new information to you. Okay, and then from there, we make our way into the stomach. Okay, the other thing I should mention is that as soon as you eat, when you're chewing up that food, we no longer refer to it as food, it's referred to as bolus, up until the point that it enters the stomach. Once it hits the stomach, we're going to have mechanical and chemical digestion occurring, and then it's going to make its way into the small intestine. The small intestine is named small due to its diameter, not its length. And then that digestive product is now what we call chyme. So it's no longer referred to bolus, it's not referred to as food, but we call it chyme. And chyme is going to make its way from the small intestine into the large intestine. And then from the large intestine, we're going to go to the rectum. And then the anus is the end of the road. So that's it for the alimentary canal. Let's go ahead and talk about the accessory organs. These are organs that are most likely involving secretions that are going to aid in digestion. So H here is our salivary glands. We're going to talk about these more specifically in just a couple of diagrams. We have our liver, which its specific role in digestion is releasing bile. We'll talk more about that later. We have our pancreas, and although it's hidden because it's a bit inferior and posterior to the liver, we have our gallbladder. Okay, so this is just our overview. The remaining, I want to say 9 pages, sorry guys, I know it's a lot, is going to talk about each of these sections individually and more in depth. Right, so let's go ahead and talk about our oral anatomy. I'm going to go a little bit out of order, but I think it'll be just fine. Of course, you have a superior and inferior lip. Lips are also known as labia. But you also have a connection of your lips to the gums, and you can actually feel those connections with your tongue. They're right in the center of each lip. The one at the top is the superior labial frenulum. My apologies. Superior labial frenulum. And then down here we also have our inferior version. Again, these are going to connect to the gums. However, we refer to the gums as the gingiva. That's why if you have inflammation, it's referred to gingivitis. I'm sure we've all heard of this. And then when we're looking at the roof of our mouth, the more anterior portion, which is a bit bony, is our hard palate. And then once you move posterior to the hard palate and the bone comes to an end, you'll feel that it's a bit softer there, which is why it's conveniently named the soft palate. And there in between where the hard palate and the soft palate kind of transition, we have that structure known as the uvula. And this is what's going to trigger the gag reflex. The portion of your, I guess the back of your throat that is kind of shared with the respiratory as well as digestive is what we refer to as the oropharynx, because it's the pharynx portion connected to the mouth. And then, of course, one of your strongest muscles, according to size, is the tongue. Right, so if we go ahead and look at this from a mid-sagittal view, again, we have our hard palate, soft palate, our uvula at the end, our oropharynx, even though that looks like a V, let me correct that. And let me correct myself now. I have a feeling that I said that the uvula is where the soft palate transitions, but it actually is where the soft palate terminates. So let me just apologize for that mistake there. We have our tongue here. And then, of course, once we get through the oropharynx and the epiglottis is in a closed position, so this here will actually close down to prevent food entering into the trachea, we have just behind the trachea our esophagus. Okay. Now moving on, I mentioned to you that chemical digestion actually begins in the mouth because we have that that enzyme in our saliva called amylase that's going to help to break down carbohydrates as we chew. And so you have quite a few salivary glands responsible for saliva production. Saliva is also going to help to dissolve any chemical matter within our food that is going to lead to taste, so that our taste buds can pick up that chemical sense. Just below the tongue, you have the sublingual gland. This is the one that, as awkward as it may be, every once in a while, if you've yawned and you've accidentally shot out saliva, that's your sublingual gland is kind of getting pinched, and it's almost like, I can't come up with a better example than popping a zit. So it kind of gets pushed and it squeezes out the saliva there. And some people actually have conscious control of that. They can actually do it on demand. And then below kind of our jaw, we have our submandibular gland. Towards the back, where we have the ramus of our mandible, we have the parotid gland. And then as the parotid gland is a bit further, we're going to have a duct to carry that saliva to the mouth, the parotid duct. Not too shabby. That was a pretty quick one. So let's go ahead and move on now. Now that we have saliva, let's go ahead and talk about the process of mastication. Mastication is our fancy word for chewing. Okay, so let's go ahead and look at the anatomy of the teeth. When we start here at the top, we have the crown. And then where the crown comes to an end, and it kind of starts to hide into the gingiva, we have the neck. And then once we make it down into the bone, which you can see the bone here, we have the root. Okay. Now I'm sure you've seen it on toothpaste commercials, but we have a covering to help protect our teeth. It's referred to as enamel. And just below that enamel, we have what we refer to as dentin. Now it's important that we maintain that enamel covering, because once that enamel wears down, it's gone. But then dentin actually has nerve fibers going through it, and so it can be very sensitive when exposed to hot and cold temperatures. It can actually be quite painful. You have a cavity here that's outlined by F. This is called the pulp cavity. And then to make sure that our teeth stay in the jaw, we have ligaments here. These are called periodontal ligaments. Remember, peri being around, dontal being teeth. So around the teeth ligaments. Oh, I'm sorry, I went off the page a little bit. And then following the pulp cavity, if we go inferior, we have this canal called a root canal. I'm sure we've heard this term before. And the root canal is going to be our essentially passageway for nerves to be able to travel up into the tooth so that they can be housed in that pulp cavity. And I am going to jump a little bit to K, because K is showing our blood vessels and nerve supply. The opening that's going to allow our blood vessels and nerves up into the root canal is called the apical foramen. Remember, foramen meaning hole. And then simply, because I skipped it beforehand when I shouldn't have, we have the cementum. Which is going to help keep your tooth in its socket, just like those periodontal ligaments. Let's move to the bottom of this. This is just showing the types of teeth. As you can see, we have our permanent maxillary teeth, in other words, your adult teeth. You also have your deciduous teeth. They're also called milk teeth. This is what you have as a baby. Most likely you should have lost all of your deciduous teeth by now, and they should have been replaced with your permanent maxillary teeth. Okay? So if we look at L, these are what we call our incisors. You have 4 of these on the bottom, that is, and 4 on the top. And then next to them you have what's referred to as your canines. For some individuals, these are actually kind of pointy. They're the ones that you think of when you think of a vampire having sharp teeth. They have sharp canines. Following those canines, you have a few types of molars. The first 2 being your premolars. These are also referred to as bicuspids. And then you have 3 sets of molars. Now, most people end up needing this 3rd molar, or your wisdom tooth, removed, and that's simply just based on jaw size. So if your jaw cannot accommodate the growth of those 3rd molars, they'll be removed. They also don't tend to show up until your late teens. And then by your early 20s, if they haven't shown up or if they haven't actually broken through, they're not likely to. And so your dentist might just choose to leave them. If they do cause problems, they'll remove them. But there's still also a population who, if their jaw is large enough, they can keep their 3rd molars with no issues. And that's it for teeth. So we've covered the mouth. Let's go ahead and move on to the next phase of the alimentary canal, which is the esophagus. All right, so we're looking at the esophagus now. As mentioned before, the part of the mouth that connects with the pharynx is called the oropharynx. That's the section that's being shown by A. And then I'm going to jump over to the right hand side because near the oropharynx we're also looking at the uvula and the oral cavity here. Once we move on from there, the region of the pharynx, the pharynx that kind of corresponds with where your larynx is referred to as the laryngopharynx. And then once we pass the pharynx and you hit that region where the epiglottis can close over the glottis at the larynx, we start with the esophagus. And the esophagus is actually quite the passage. It's pretty long, and it's going to come to an end after it passes through the diaphragm. And once it passes through the diaphragm, that's when we can finally make our way into the stomach. Now there's a sphincter here, which is very important. It's called the esophageal sphincter. When it's open, it's going to allow food in, and then it should be closed. If there is any type of faulty mechanics going on here, it's going to cause acid reflux so that the acid can actually travel back up if it's not closed properly. And so for quite a few individuals who struggle with heartburn, it's because they're having issues with the esophageal sphincter closing properly. This can also lead to like ulcers and things like that in the esophagus. Now that we're through the esophagus, let's go ahead and look at the stomach. I know this is overwhelming in appearance, but I promise it's not that bad. All right, so let's just go ahead and go over this. The top part of the bean that is your esophagus. My apologies. The top part of the bean shape that is your stomach is called the fundus. The upper part is called the cardia. And then where it's curved, where we have that arch shape, on the top of the stomach is called the lesser curvature. And then because, of course, if this is the lesser, the larger portion of the curve is going to be the greater curvature. Now the stomach's going to play a huge role in mechanical digestion. There's going to be a lot of contracting and relaxing and kind of churning to help digest anything that enters the stomach. So we have multiple muscle layers here, or muscularis layers. If we start on the outer layer, we have our longitudinal layer. And you'll see that the fibers are actually running in this direction. from there we have our circular layer. And they're running around the stomach. And then running at a kind of diagonal, we have the oblique. And then the outermost is just the body. Now you'll notice that the inside of the stomach has these really strange, kind of like squiggles. These are called rugae. It's important that our stomach has rugae because when the stomach is empty, it's going to deflate to a fairly small size. So whenever you're ingesting, essentially food, there's going to need to be expansion, but we don't want to have any tearing in our stomach. We want to be able to expand with the food. And so those rugae are like ridges that are going to allow expansion to occur in the stomach. And then once we get to the bottom portion or inferior portion of the stomach, we have a region called the pyloric region. It's got a couple different sections here. First, we have our canal, which is it's kind of like our pathway here. So this is the pyloric canal. And here at this canal, we're going to be lined with what we call a sphincter. So it's like a circular muscle. Okay, this is going to allow closure so that when there's mechanical and chemical digestion occurring in the stomach, we don't accidentally have anything making its way into the small intestine before it's ready to actually move on. And then L is called our antrum. And so the antrum is just what we refer to as the pyloric region. So this is just before we get to the pyloric canal, this space here. So this is our antrum or pyloric region. We then make our way to the pyloric canal, which is surrounded by that sphincter, and then we can make our way into the small intestine. So if we look at the bottom here, this is just showing some of the microscopic sections here. Sorry, just trying to figure out where I want to start. So if we look at our different muscular layers, we have our oblique, circular, and longitudinal. The layer aside from the longitudinal is the serosa. And the serosa is kind of like a visceral, I guess, membrane that's around the stomach. And then internal to the oblique, we have the submucosa. And the submucosa is it's just kind of a layer that's a very vascular in this region. And then P is our mucosa. And our mucosa layer is going to have a lot of secretions here. We need to have acids that are being secreted. We need enzymes being secreted. This mucosa layer is going to be responsible for the secretions that are going to be necessary for the chemical digestion portion that's going to take place in the stomach. So again, we've got, if we start on the outside, our outer membrane of the stomach is our serosa. We then have our longitudinal, our circular, and oblique muscular layers. We have our submucosa, which is the layer just below the mucosa. This is going to be very full of different blood vessels to essentially nourish the mucosa. And then the mucosa is there so that we can have the necessary secretions for chemical digestion. If we take a look at just this cutout here, we're looking at just the surface of the mucosa. We have a couple things going on here. Where we have this section here, M, where it's kind of like a gap, this is called a gastric pit. And at the bottom of that pit, we're going to have parietal cells. And then in the tissue, kind of next to those parietal cells and this gastric pit, we have chief cells. These gastric pits are going to have parietal cells and chief cells letting the secretions into that gastric pit so that we can have the chemical secretions that we need for chemical digestion. Right, so now that we have covered the stomach, let's go ahead and move on to the next organ in line in the alimentary canal, which is our small intestine. And we're also going to cover just a couple of the accessory organs here. So while here C is showing our upper portion of the small intestine called the duodenum, it is surrounded by the pancreas and the gallbladder. Now, the duodenum is kind of like the first step from, or stop off of the stomach. This is where the material leaving the stomach is now called chyme. And it's necessary that it enters the duodenum where we have the gallbladder releasing bile, because that bile is going to allow reduction of pH of that chyme and kind of, I guess, neutralizes the acidity. It's important that we take the time for chyme to slow in the duodenum so that its acidity can be neutralized. Not to be too gross or anything. I mean, I don't know else how to say it. But if you've ever been in the scenario where something just really didn't agree with your stomach, and it forces whatever's in your stomach to evacuate, so you essentially have to have diarrhea. If it doesn't spend enough time in the duodenum, it's going to burn. And so that's why a lot of people associate diarrhea with burning, because it didn't have time to neutralize in the duodenum, and so you still have acidic material making its way out of your body. Anyhow, after we have the duodenum, your upper 2/5 of your small intestine are referred to as the jejunum. It's a fun word. And then once it is through those upper 2/5, it makes it down to the ileum. Here is where spelling is key. Ileum here is ILEUM. Not to be confused with the ilium of your pelvis. Ilium of your pelvis is spelled ILIUM. So that is that's especially important to make sure you're spelling correctly. Now anyhow, in regards to anatomy, in regards to physiology, as chyme is moving through the small intestine, it's throughout the small intestine that you're going to have nutrient absorption. And in order for nutrient absorption to occur, you need to have maximum surface area so that chyme can come into contact with the walls of the small intestine. And so if we look at the actual layer, the lining of the small intestine, we have a lot of these ridges here to maximize the amount of surface that can be absorbing nutrient. Okay? And so the larger portion shown here in F is called the circular fold. G are little finger-like projections called villi. And again, these villi are going to help increase surface area so that we can absorb more nutrients within our small intestine. Below that, we have our submucosa. And then because your small intestine consists of smooth muscle, we have the muscularis. And then just to make note here, the circular fold is only found in the jejunum. Once you get into the ileum, those circular folds disappear. Now, even though it's not really mentioned in the reading, I do want to talk about this muscularis. The small intestine is actually a very long tract within your digestive system. And that means that whatever material makes it out of your stomach has to make it through all of these folds and loops of your intestines. And gravity alone is not going to help pass those materials. You're going to need some type of muscular assistance. This muscularis lining or layer is going to go through contractions that we refer to as peristalsis. And essentially, peristalsis is kind of like a wave of muscular contraction, so that as it forces contraction throughout the intestine, it's going to push the chyme along so that it can make its way to its end goal. All right, we've covered small intestine and nutrient absorption. Let's talk about the large intestine. This is where we're going to have water absorption. So for the large intestine, with this diagram, I'm going to go a bit out of order just because I think it makes sense to talk about it in terms that the material is moving through it. So kind of step by step there. In the first stage, once we leave the ileum of the small intestine, we make our way into the cecum. The cecum of the large intestine. And from the cecum, we're going to move up, which is why this is called ascending. We're going to move up in the colon, so the ascending colon. As soon as we turn direction, right here, this is referred to as our hepatic flexure. It's also kind of like where the liver would be, which is referred to as hepatic. And then we're going to move across in the transverse colon. From there, you're going to hit another sharp angle called the splenic flexure. That's because this is where the spleen is, near. And then as soon as we start moving downward, we refer to it as the descending colon. We have these appendages here. So you can see these are our epiploic appendages. And then right at the end here, this portion of our colon is the sigmoid colon. Once we have reached the end here, we have our rectum, which is G. H, once we get this narrowing, is the anal canal. And then I is the anus, which is the actual opening. And then I didn't mention it before, but attached is, I don't know if you can see this. We simply, in common, like when we're just talking about it day to day, but we talk about it as the appendix. It's technically called the vermiform appendix. This is essentially like a vestigial organ, meaning that they think it might have served a purpose, in, say, our previous ancestors. But as of now, not so sure what its purpose is. We know that it holds a lot of bacteria, and that its rupture can be fatal because of that bacterial introduction to the body. So appendicitis or inflammation of that can actually be very dangerous. If we look at this kind of zoomed in section here at the bottom, we're looking at E again, which is our epiploic appendages. And then we have, again, smooth muscle, because we need this smooth muscle to help fight against gravity so that we can get through the ascending and transverse portion, as well as those turns in the intestine. So that muscular area, or that muscular line that follows, is the Tenia coli, or Teniae. And then all of those compartments that you see throughout, so like this right here, each compartment is called haustra. Okay? And then again, not to keep bringing up diarrhea, but we already mentioned that if it vacates from the small intestines too soon, you have that acidity to it. But the other problem is that water absorption is occurring in the large intestine. So if there's no time for that water to be absorbed, that's why your, bowel movement is no longer a solid, because that water is not being withdrawn from the contents. Okay, so we've covered the alimentary canal organs. Let's go ahead and talk about some of our accessory organs responsible with digestion. So let's go ahead and talk about the liver here. When it comes to the liver, we've got two lobes here, thankfully named by common sense. We've got our right lobe and our left lobe. Lobe, not love. Let's fix that. There we go. And these are separated by, even though it's similar to a fissure, this is, let me backtrack. Even though we have lobes that you would typically think of as being separated by a fissure, these lobes are actually separated by a ligament. This ligament is going to help with attachment to the diaphragm muscle that runs alongside of it. And that ligament that's going to connect is called the falciform ligament. We're looking at a posterior view in this second half here. So again, this here, I'm just going to trace it. This is our right lobe. And over here we have our left lobe. And then here at C we have our ligament, our falciform. But we've also got quite a few different arteries and veins going through this area. If you look at E, This is our hepatic artery. So this is our blood supply going into the liver. And then if you look at D, this is our portal vein. Or also referred to as the hepatic portal vein. If we look at G, this bottom portion here, we have another lobe in the posterior side. This is our quadrate lobe. And above that, we have another called the caudate lobe. So the caudate lobe is posterior, superior, and the quadrate is posterior, inferior. And then for this bottom diagram, to be perfectly honest with you, I think it appears a bit confusing. So this is not something I'm going to hold you responsible for. I just want you to know that there are hepatocytes and liver cells in this area that are going to clean your blood. They're going to, I guess, filter out toxins. But then you're also going to have old blood cells that are used to be converted into bile, and that bile is then going to be stored in our gallbladder. Now, in the case that somebody doesn't have a gallbladder, say it's been removed, what will happen is that the liver will just be required to produce more bile when needed, or it will be stored in the bile duct. Let's go ahead and move on to the next page, which is our gallbladder and pancreas. So A is showing our gallbladder. B is our pancreas. And then C is going to be our duodenum. Now, pancreatic anatomy here is pretty simple. The portion that rests within the duodenum is the head. We then go from the head to the body, and it tapers off into the tail. If we go ahead and look at this in regards to bile coming through, again, where our gallbladder is here, we have a duct called the cystic duct that's going to make that connection to our hepatic duct. And our hepatic duct actually has multiple branches. Well, we have our common hepatic, which is made by our right and left branches. This is our left hepatic. and our right hepatic. Once we have that hepatic duct and the cystic duct meet and kind of fuse together, we then have what we refer to as the common bile duct. And again, if somebody doesn't have their gallbladder and this cystic duct has been kind of closed off, that just means that we no longer have the gallbladder to store bile, and the bile storage will need to take place here in this common bile duct. Where that common bile duct makes its connection with the duodenum, it is what we refer to as the duodenal papilla. And then we also have here, heading to that area, it's like a common place, is this pancreatic duct. And so this is where we're going to have not only the bile being released, but any pancreatic secretions being released into the duodenum. And that covers digestion. If you have any questions, let me know. I know that it was a whole lot of information, but I think that these diagrams did a pretty good job of separating the alimentary versus accessory.